Greetings. My name is John T. McDevitt. Welcome to today's continuing dental education lecture on the topic of next generation intelligent cytology test for oral lesion diagnostics. I am a professor of biomaterials at New York University, connected to the College of Dentistry there with joint appointment in the Tandon School of Engineering. In today's lecture, we're going to speak and feature next-generation diagnostic devices and their potential to deal with the current gap in oral cancer diagnostics. We'll be talking about the problem, the solution, which involves next-generation cytology test, methods that we can use these new capabilities to detect precancer lesions, and then I'm going to focus on bringing in a clinical workflow that works in primary care to take advantage of these new capabilities and also look at the more advanced use of these capabilities in secondary and tertiary settings. I also want to acknowledge that I have a second important role in this lecture of moving these academic activities into real-world clinical practice. And in doing so, I serve as the chief scientist and scientific founder for Oraliva. So let's begin with the problem now. Stated succinctly, doctors and dentists now lack effective tools to diagnose oral lesions. This is a growing concern affecting about 10% of the US population. And unlike cervical cancer, where we have effective tools that have largely reduced the problem with cervical cancer, in oral cavity cancer, we lacked these kinds of capabilities. And this disease, unfortunately, is still diagnosed late stage. It's deadly. It's expensive, it's one of the worst cancers you can get, and it's one of the most expensive to treat. So let's look at this problem in terms of the sheer numbers, focusing on the number of patients in the United States. So there are around 50,000 oral cavity cancer patients diagnosed each year, but the problem is much broader than that, and there's about 14 times this number of patients in oral epithelial dysplasia, about 700,000. And if we expand oral lesions into a more common region of oral lichen planus, there are now 50 times this number of lesions. So today we tend to focus mainly on the tip of the iceberg. But to be successful, we need to look at the lessons learned from cervical cancer, where it's not a focus on the cancer itself, but rather finding the disease at the precancerous stage. We need new technologies to make that happen. Now, if we look at the statistics of a US primary care dentist seeing about 3,000 patients a year, about 300 or 10% of them have oral lesions, and about 1 in 4 or 75 of them are oral potentially malignant disorders, OPMDs. And these OPMDs, ideally, you would like to have them referred for expert follow-up, but the statistics today show that GP dentists are referring about 9.5 per year. In other words, 1 in 8 referrals are happening at this moment, and the referrals that are happening tend to be very late stage. So why does this happen? At some level, we're in a dark room without the flashlight to see effectively at the cellular level. We don't have the capability that a Pap smear provides to look at the cells and find the cancer at this stage. And we're left with a much more invasive scalpel or punch biopsy to provide some information about the health of the particular patient. That creates a burden on the clinician to decide whether or not to subject a patient to that particular follow-up. So this is an under-addressed disease that is in plain view, and 50% of oral cavity cancer today is not caught at precancer, but it's caught at stage 3, stage 4 oral malignancy, with the size of the lesion on the order of a quarter. And the cost to treat this patient is over $100,000. But when this disease is caught early, the survival characteristics at stage 1 ramp up to 80 to 90% and fall below 30% at stage 4 cancer. So we are driven by a desire to capture this cancer early on, and ideally, like cervical cancer, in the pre-cancer stage. So mainly what we'll be talking about here today is a focus on oral squamous cell carcinoma, which accounts for 90% of the oral cavity cancers. And we would like to identify these lesions when they are smaller, because that leads to better outcomes. Now, let's take a comparison look at cervical cancer and oral cavity cancer. These two cancers are very similar in their growth rate. If a cancer grows too fast or too slow, it's not ideal for an effective screen. But both of these cancers grow at approximately the same rate. Now, cervical cancer, since the 1950s, has had the introduction of the Pap test, and as a result of that, there is now an 80% reduction in the incidence of this disease, and the mortality has dropped 70%. Look at oral cavity cancer in comparison. There is a 34% increase in the incidence of the disease, and the mortality has also increased. The cytology or cell-based diagnostic test that include the Pap smear is now done at 8.5 million a year, and only 250,000 is happening in oral cavity cancers. We have 3 times the number of deaths now in oral cavity cancer, and there's a huge opportunity for us to make a difference and change, and the dental community is ideally placed to make this difference. Now, looking more specifically at the cervical cancer screening, it begins with a visual inspection of the cervix, and then steps 2, 3, and 4 happen before histology. And that's key. This involves liquid-based cytology, HPV testing, and colposcopy. And these are 3 steps involved in the escalation of the diagnosis before the histology and the scalpel collection of the tissue happens. Now, oral cancer screening today, a visual and tactile exam, is part of a way to find the oral lesion, but it lacks an effective capacity to do the things that have already happened in cervical cancer. So it's fair to say that we do not today have an effective overall screening capacity to detect these lesions at the mild epithelial dysplasia stage to be analogous to what happens in cervical cancer. Next, let's look at the diagnostic flow which is happening in the US today. In medical and dental centers, we have GP dentists and doctors often referring to oral medicine and oral pathologists. But in this environment, there are only about 300 oral med and 300 oral pathologists in the United States in total. This particular area, for those 5% of patients, leads to better outcomes, and the disease is caught earlier. About 50% of oral cavity cancers goes through the medical infrastructure where ENT and GP doctors find this disease In general, this focuses on later stage diagnosis and poorer outcomes. Today, I want to focus mainly on this third sector, on the generic dental coverage, i.e. outside of the centers of excellence. And in this particular environment, the most common referral pathway is between GP, dentist, and oral maxillofacial surgeon. Here, we have about 9,000 OMSs in the US, and it's important to note that their preference is typically to have a referral which is clinically actionable through their surgical intervention, and that involves a patient referred that has severe dysplasia, cancer in situ, or oral squamous cell carcinoma. This today leaves the moderate and mild dysplasia in no man's zone, and we want to address that issue in developing a new solution that's effective and allows us to capture these cancers early. So now let's focus on the solution. We're bringing into clinical practice now AI-linked cytology that is compatible with the point of care. Now, this is a cell-based diagnosis, and in essence, we have a capacity to see cancer better by linking AI to large databases and putting this in a package that collects cells and images cells in a modality that is compatible with chairside measurement moving forward. So I'll come back to this, how we do this in a second. But overall, this is a new type of cytology. And if we look at what's happened recently in the cervical cancer, where this is dominant now, this began with a Pap smear, and that's moved into liquid-based cytology, which now processes these cells in a more effective way. And the third element, intelligence cytology, brought to us by microfluidics, uses fluorescence-based imaging in 3 color channels and artificial intelligence to find and select these particular cells. So this particular approach is coupled to a non-invasive brush biopsy sampling. We use an Oral Selects brush that gathers the surface cells and moves transepithelial to get all the cell types that are necessary and useful to make a clinical diagnosis. Now, in the cartridge that makes this measurement, we collect cells in a single layer, in a monolayer form, and we stain them with 3 fluorescent dyes. So we have a red channel, which is phalloidin-based, which basically labels the cytoplasm so that we know where the cells are. We have a DAPI, or a nuclear stain, which hits the nucleus blue. And then we have a green biomarker expression channel, which pulls in additional information related to protein biomarker expression. With the stained cells, we then do data extraction. We have multispectral fluorescence in these 3 different colors. We begin with that combined image in 3 colors. We then define the cellular boundaries, which hits the cytoplasm, the nucleus, and creates different compartments in the cells. And then we analyze these areas of interest and bringing into play nuclear cytoplasm and molecular biomarker parameters to give us information about what's happening in these cells. Now, this particular data is backed by a number of large, unique clinical studies. The Oral Cancer Collaborative team is shown here, spanning oral medicine, oral pathology, ENT, molecular biomarker expression, microfluidics, deep learning, artificial intelligence, and health economics. So many different aspects contribute to understanding this disease and creating a better way to detect this disease earlier. So one key thing I want to focus on here is a unique clinical study that was funded by Renaissance and NIDCR, division at NIH. This is what we describe as our GO study, and it collected data on 999 patients across a series of different diagnostic categories, and it brought into play some of the best pathologists in the world that allowed us to understand where these patients are in their diagnostic journeys. Now, I'm going to focus on these 7 different diagnostic categories, going from no lesions on one extreme into oral malignancy on the other extreme. And for US population, I mentioned before, we have 50,000 patients in that particular area, but I want to highlight that it arguably is less important that those 50,000 patients, but if we want to save lives, then we need to think about capturing this disease in the dysplasia stage, mild, moderate, severe dysplasia, which are now labeled as 3, 4, and 5. And key to mention this is with the mild dysplasia, 7% of them convert to cancer over the next 5 years, and at severe dysplasia, that's up to 44%. So there's a very significant potential for those patients to be high risk, and we really need to monitor them in order to save lives. That needs to be our new focus. So going back to GO, the Grand Opportunities Study, this is how we collected data on over 1,000 patients. We had a series of microscopes and a flow cell and a XYZ stage that stitched together 25 different images. They were Z-merged at different focal heights, and we gathered 13 million cells imaged in this particular way. This has a series of manual steps, and this gave us robust data on what the cells look like. So this is data collected via a chip in the lab. And we will move past that as we go forward, but that is the original origin. Now, as we began this particular study, we needed to understand when should we find this particular disease, and we spent many years looking at the different diagnostic splits, 2, 3, 3, 4, 4, 4, and 4, 5. And what I'm going to focus on today is the diagnostic split that is in between moderate dysplasia and severe dysplasia, because that's what the OMS would like us to do, to provide them what they consider a case, what they would act on clinically is that particular case. But as I look at our study here, if you go to the diagnostic case of mild dysplasia, you see that our oral pathologists disagreed 70% of the time. So this is one of our first challenges here with some of the best pathologists in the world. They don't agree on what the diagnostic outcome is for arguably the most important place where we want to capture the disease. So this forced us to take another important step, and this is now published in Quadruple O and is becoming a standard in this particular area. We had to go from a tarnished gold standard, relying on individual pathologists, into an enhanced gold standard to define the truth. And that truth we now get from 4 stages of adjudication, and that after 4 stages, then we go from an initial agreement of 69% into 100% agreement. And that enhanced gold standard, again, not relying on an individual pathologist statement of where a patient is at to a consensus agreement, and that is used to train the AI-linked diagnostic models that I'll feature next. So this large study created this huge database. Again, this is data acquired from an international prospective study. And so this is pre-diagnostic. We avoided the temptation to bring in extreme phenotypes and work through a clinical workflow that is more typical in real-world practice. We acquired the data, we warehoused it, we created predictive models. We have 40 terabytes of data, 13 million cells, individual cells, 165 image-based attributes, and that became the basis for us to create and understand which variables are most important. So we went into the study reading the literature and understanding what was thought to be the most discriminatory variables, but left that aside, and we used the statistical methods and machine learning and logistic regression and lasso-based approaches to tell us exactly what variables are most discriminatory. So this involved us looking at risk factors, lesion appearance, lesion location. The literature taught us that nuclear cytoplasm ratio was a dominant variable. Patient demographics, biomarkers, microbiome, DNA signatures, all of these are throughout the literature as deemed as important. And we looked at all of these to get a sense of what was the most key variables. So we begin initially by looking at these variables one at a time. And an interesting thing I want to share at this moment is that we found 128 variables that are more important than what the literature taught us when we began this study. Variable 129 here is the nuclear cytoplasm ratio. It's discriminatory, it's decent, but there are much better ways for us to find oral cavity cancer and to find oral epithelial dysplasia. If you break this down even further, you find a lot of the important variables are cell-based diagnostics. The red and purple are showing these key variables, and that's an important clue. And so if we look at what we now defined as 5 new ways to find this disease, we created these 5 cell-based phenotypes, starting with squamous cells, small round cells, white blood cells, and lone nuclei, and then looked at them and the percentages and how they varied as the disease evolves, going from normal to benign, through dysplasia, and then on to severe dysplasia and cancer. And you see the normal squames drop off, they fall down, and the small round cells and the leukocytes begin to uptake. And one key type of squamous cell, which we now describe as nuclear actin positive, this is a key variable for finding mild and moderate dysplasia. That begins to kick up, and it's a rearrangement of nuclear actin, which is a new observation that begins to shrink wrap and find itself at the nucleus. Now, recently, we've taken these 13 million cells and begun to apply powerful deep learning strategies to identify and localize these cells. And I'm focusing on 4 of them now, the DSCs, the small round cells, the leukocytes. And these become important to determine where a particular patient is at. So I'm going to put this in perspective here initially by giving you a sense of what happens for a couple of these key cells. So with the normal squamous cells, I'm now showing you in the left-hand panel a healthy patient which is measured a total of 5 times. So same patient, a cytology-based test done 5 times, and that percentage of 96 plus or minus 1% is what we see. The oral malignancy shows 54% of these normal squames. So it's not every cell is deemed, quote, malignant, but there are these percentages changes which are consistent. Now, looking at the small round cells, we see a different kind of behavior. For the cancer, which is shown in the red, there's 37 plus or minus 2, and the healthy is 2 plus or minus 1. Again, we're repeating the same measurement 5 times. Okay, next let's take a look across the entire 999 patients in this study. Again, we're looking at normal squames now as a function of disease severity. And what you see here in these bar and whisker plots is that there's a progressive decrease in the normal squames as we increase disease severity. But I'm introducing now the Spearman's rank correlation, which is a measure of the monotonicity of that particular correlation, and it shows a strong negative correlation. In other words, this particular metric becomes a good biomarker by itself in telling us a bit about a given patient and its disease severity. The small round cells do a similar thing. In this particular case, it's a positive correlation, and Spearman's rank correlation, again, is very significant in this particular area, as is the P ratio. And for the white blood cells, there's a similar capacity. There's clearly a tendency for white blood cells to infiltrate and move into these lesions, and this becomes an extremely good biomarker that allows us to evaluate the disease severity. So up to this point, I've been focusing on individual variables, but more powerful is the introduction of machine learning and deep learning to move across all of these variables simultaneously. And what we found is that we have a multivariate model which is much more accurate than these individual variables, but included in this model is lesion size, lesion color, patient age, tobacco use, and these cell-based metrics, the percentage of these cells producing ultimately one output: an oral cancer numerical index, an OCNI score, which is super reliable, and one metric that combines all these behaviors into a single metric to monitor patients' disease severity. Now, this particular OCNI plot shows a numeric index evolving again as a function of disease severity. And again, we have this monotonic increase as the disease severity comes into play. Now, putting this multivariate model into play and focusing on what we believe to be the most important diagnostic model, we find across a real prospective patient population that we have an area underneath the receiver operator characteristics curve of 0.92, a fabulous and excellent diagnostic accuracy. But putting this into perspective, to be accurate here, we need to look at real-world patient populations. Many new approaches start with a few patients and look at only the extreme, benign versus cancer, or no lesion versus cancer. And if we simplify our study, eliminating the 3, 4, 5, i.e. eliminating the dysplasias, which again are 15 times more prevalent, then it's easier to do the diagnosis, moving this number up to 0.95 versus 0.97. Now, let me take you into the future now, into phase 2. And this is where we are today, building capabilities that have the capacity to move chairside. Now, this happens when we go past that microscope and manual manipulation of fluids in a lab with people in white coats into a microfluidic-based approach. And again, this is not future-minded. This is today. We're doing this today, eliminating the infrastructure that you see here and creating a workflow that is compatible with bringing all these capabilities chairside. We're using this new technology in an NIH study now for time course monitoring of oral epithelial dysplasia and recurring cancer with a group of leading clinicians shown here on this particular slide. So this data now, we believe, is creating new capabilities that will empower primary care clinicians, dentists and doctors, to provide expert-level care by providing the information that comes from these intelligent cytology measurements that are made with microfluidics. The capabilities that we're using today in this area involve the clinical kit that is seen here, and we're using OCNI now as basically a thermometer for cancer. And I want you to focus on two cut points here. Again, the OCNI, this numerical index, is like a thermometer, and it goes between 0 and 100. And the higher the score, the more pushing towards malignancy. The lower the score, the more pushing towards extreme oral health. When we hit 38, we begin to hit the signature of mild dysplasia. When we hit 55, we begin to push into severe dysplasia. And so we have 3 zones now: surveillance, ultra careful surveillance, and referral that come into play with these different endpoints. Now, I want to propose a new kind of capability. With these expert level capabilities moving into primary care, we envision a new paradigm that begins with the old paradigm, where a screening population in a routine dental care would undergo a visual and tactile exam. If a lesion is found at this moment, there is a pre-screen, an oral lesion pre-screen, that looks for one of 3 things: the lesion color, the lesion size, or the smoking status. If one of those 3 boxes is checked, that patient is at elevated risk, and it warrants going to the oral AI-linked cytology test that I'm featuring here today, and that then brings in that OCNI score, which has these 3 ranges. Now, let's take a look at this cytology capability in real-world practice. I have a healthy cytology specimen that I'm going to walk through the report of OCNI and the OCNI score 5 times. One patient 5 times. So the score is 15. And again, this is an indication of a healthy patient. Next sample measures 16. The third sample measures 17. The fourth sample 16. The fifth 15. Now, all of this, so you see very different measurements of the cells, but they all use this algorithm to report that OCNI score, and they cluster around that value. Here's a picture now of an oral squamous cell carcinoma specimen. Trial 1 is 70. The second measurement, exactly the same. So different cells, but same value. The third is 73. The fourth is 72. The fifth is 72. And looking at this from the OCNI perspective, from the Oral Cancer Numerical Index, we find that this particular score, even though the cells are different, their signature, their cytosignatures are leading to the same element of risk as represented here. So healthy is showing up as 16 plus or minus 1, and malignancy is 72 plus or minus 2. So we're looking at this in the context of putting together these clinical reports. This would show the focus on a couple things. The referral index here, the disease severity that I featured up to this point with a couple clinical endpoints, but underneath that, in that gray-pink scale, is a second intensity score, an oral lichenoid condition score, which is looking at more benign lesions. So I'm now going to take you into a crystal ball, and I think this is looking a bit into the future, into what is possible once you have a precision lesion diagnostic. You can begin to look at your patients and follow them with time. And this is what we're doing now at NYU and in MD Anderson and in Texas now. We're looking at patients as they come in, visit after visit. We're looking at the OCNI score and what happens, and can we distinguish a patient that will undergo malignant transformation from a patient that may be regressing in disease versus a patient that's staying static. Again, I would consider this the holy grail in this particular area, but we are seeing evidence that we can make this ability to distinguish these classes of patients, as I'll show you here. Now, this particular situation may be associated in many cases with patients that have been referred to secondary and tertiary care, but in some cases could be oral lichenoid condition patients which are less at risk, and we're looking for patients evolving in their disease severity. So we have an additional dynamic on the right-hand portion of this particular slide. We have patients that have been found to be at risk and have been referred and have an OCNI score, let's say, greater than 55, and now are moving into surveillance and looking at these patients as a function of time. So I'm now going to give you a sneak preview of what we're actually seeing when we do this. And again, this is, I think, an exciting view of the future. And I'm going to challenge you here with a new kind of metric to look at the particular patient. And this is a mouth map. And what we're doing is superimposing on this mouth map a simple way to see where the lesions are and how extreme they are. So think of this as a disease severity map, a heat map. And so a red lesion is, let's say, a cancerous lesion. A blue or green lesion is more healthy. Now, in this study, we have to acknowledge that in some of these lesions we can see, and some of them may be prior lesions that made the patient eligible for our study, but that lesion is no longer there. And for controls, we also brought in contralateral. So the outline of this particular lesion will give you a sense of these different types of lesion. And then this black dot is where we do the scalpel or punch biopsy in the selected cases. But what's interesting about this particular capacity is it now gives us an ability to measure what's going on at these lesions at a time that is pre-threshold for histology, and that's key. So there's a lot here in this particular slide, and I just want to go over the highlights of this. This is our patient 14 in our oral epithelial dysplasia arm. This particular patient had a history of oral lichen planus, and we're looking at the time course. And to the left at -44 and -3 months are patient visits that happened before we began the clinical study. Visit 1 is when we enrolled the patient at time is equal to 0. And in this particular case, there was one lesion which has a yellow color. So this is showing up in this intermediate zone. It has a score of 56. I put a red flag here because that 56 is now in the troubling zone. And we also looked at the contralateral lesion, which is in the green zone. It has a score of 6. But interestingly, the clinical judgment of this patient at this moment had no scalpel biopsy recommended. So we are now seeing evidence for early information, pre-threshold for the scalpel biopsy. Visit 2, same thing. But interestingly, this lesion, which again has a red flag, has moved from 56 up to 60. Perhaps more importantly is the contralateral lesion. It's gone up from 6 to 24. And while that still is kind of low, it's not low for this patient. And that movement from 6 to 24 is way outside of the experimental error for this kind of measurement, which is about ±3. And so that in itself is a concern. At visit 3, at that moment, the red dots indicate a punch biopsy, and that went to histology. It was done at 3 spots, and these span severe, mild, and moderate dysplasia. So and we find that also with the cytology that we did at that particular moment, but I'm focusing on this early information. Now, this second patient is maybe even more interesting here. This is an HIV positive patient, and this is in our recurring cancer arm. And this patient too had 2 visits before we began the study. Visit 1 was our recruitment, and at this particular moment, we see 3 lesions. And one of them has a score of 86. There's also 3 contralateral lesions. So we gathered a total of 6 measurements, 6 different brushes in this visit. On the second visit, same thing. And we went from 1 lesion, which is very troubling, beginning at 86. Now it's up to 89. So this lesion is getting worse. But we pull out, again, 2 visits before the clinical visit results in a scalpel, or in this case, a punch biopsy. And at that moment, 83 is found in the cytology. And so this is a more sophisticated situation. And from this study, we've found reason to pay attention no longer to the individual lesion. The patient is not defined by their lesion. The patient is defined by the full oral biology in the oral cavity. We can say that with some confidence now, and we find patients presenting with multiple oral lesions. They're now 300% increase in their chance of malignant transformation. So this has pushed us in the direction of developing another quantitative score which we describe as Field Oral Cancerization Universal Score, or FOCUS. And basically, FOCUS is a quantitative measurement of the overall patient risk for malignant transfer, moving past those individual lesions. When you look now at this same patient from this perspective, you'll kind of get a sense of where we come from here. So this is looking at timelines of these 3 visits. At the initial visit 1, at t is equal to 0, at 1 month, and at 3 months. And I had that red flag on this troubling lesion, but we have 5 other lesions that are characterized in this evaluation, and we're able to do that because we have a non-invasive cytology approach to do that. If we were focusing on only 1 lesion, we may miss this cancer if the focus was on either those 2 lesions. And what's interesting about this is when you begin to look at the focus, which is shown in blue at the right, and again, this is every single lesion, its OCNI score, and the OCNI score for the contralateral spot. Those are summed together, and that creates the 297 and the 295 are basically the same number for the 2 first visits, and then the 3rd visit, it explodes, moving outside. But it's not exploding because that most severe lesion, in fact, the most severe lesion looks like it's stabilized a little bit, but the contralaterals have jumped up a lot, and it looks like the whole cancer field is moving through this particular oral cavity. So I think there's a capacity now, a new capacity to look across the oral cavity. So as I move now to close up this CDE lecture, I want to put this into perspective. At the beginning of this lecture, we looked at cervical cancer, the focus on women having a series of adjunctive tests, including the PAP test or liquid cytology test that moved a step past the visual exam. And there were 3 steps. In the oral cavity area, we're now proposing an analogous 3 kinds of steps. And the first involves the pre-screening. Not every patient that has an oral lesion, we believe, is at risk and warrants this test. But if they are at elevated risk with the 3 metrics, if they get a checkbox in one of those 3, we have statistical data to show that that's the case. That then moves on to the AI-linked cytology, and that in the GP dentist area would create a referral with confidence if that patient hits the appropriate metric. In some cases, we need to do surveillance, in other words, looking at a patient over time and looking at their individual scores to look for conversion, let's say from a lichenoid lesion into OED, or to look from OED, from mild dysplasia, becoming oral squamous cell carcinoma, or having a recurring cancer come back. So those 3 steps we feel are key to place a focus on early disease diagnosis and ultimately move patients to histology, but move the right patients in that particular direction at an earlier stage. So next, I'm going to show a movie which covers the process flow, something that I describe as the provider movie. And what this does basically is it shows the pathway that we have going on to move from these academic findings into clinically actionable capabilities through the partnership that we now have with Oraliva, which is now moving this technology into real-world practice.
The Oraliva OncInsight platform is the world's first AI-linked cytomics-on-a-chip technology that allows clinicians to identify early signs of cancer at the cellular level. Current screening tools are only sensitive enough to detect late-stage disease. However, there are 15 times more cases of oral epithelial dysplasia in the US relative to oral cavity cancer. With their groundbreaking platform, Oraliva is poised to usher in a new standard of care that empowers frontline dentists and clinicians to identify and refer patients with early-stage disease. Providers that request an OncInsight test are sent a sample collection kit, which includes a test requisition form, an illustrated user guide, a sealed sample collection brush, a sample transport tube containing 5 milliliters of cell preservation media, a specimen transport bag, and a pre-labeled shipping envelope. Before collecting a sample, complete the paper requisition form provided in your kit, or submit a digital version available online. If multiple lesions are to be analyzed, please use a separate sample collection kit for each lesion. When ready to collect the sample, remove the brush from its packaging, ensuring to only touch the blue handle. Place the cytology brush in direct contact with the lesion site. While applying firm pressure, rotate the brush 360 degrees approximately 12 to 15 times in the same direction. For lesions that are larger than the size of the brush, make sure to sample the entire area of the visible lesion during this process. For sensitive lesions, brush sampling can also be performed after the application of a topical anesthetic gel. If topical anesthesia is used, make sure to check the corresponding box in the test requisition form. Immediately after the sample is collected, remove the cap of the sample transport tube and insert the brush. Push the clear applicator on the neck of the brush downwards, popping the brush head off while avoiding direct contact. Ensure that the brush head is submerged in the transport solution and tightly replace the cap on the tube. Fill out the patient name and date of birth on the provided sample tube label and affix to the sample tube. Place the tube in the specimen transport bag. If you are using the paper version of the test requisition form, insert the completed form into the document sleeve on the specimen transport bag. When ready to ship, place the sealed specimen transport bag into the pre-labeled shipping envelope along with a copy of the patient's medical insurance. After the cell sample is received at Oraliva's CLIA certified lab, cells are added to a disposable cartridge and inserted into Oraliva's automated analyzer. Within the analyzer, fluid-filled blisters on the cartridge are compressed, isolating and labeling the cells with fluorescent dyes. The fluorescent signals are then recorded with the instrument's multispectral fluorescence imaging system. Using artificial intelligence, Oraliva's cloud-based analysis software translates these complex cytosignatures into an intuitive cytology score. With a strong clinical foundation from an international prospective study, Oraliva is excited to begin offering the OncInsight test to providers in a regulated, CLIA-certified setting. To request an Oraliva OncInsight lesion report for your patients, please fill out an inquiry form at oraliva.com.
In closing up my presentation, I want to summarize some of the key things that I've talked about in this continuing dental education lecture. First, we've taken a look at point-of-care capabilities for AI-linked cytology that delivers new information for dentists and doctors that are involved in evaluating oral lesions. These capabilities, when brought to point of care, will deliver results under 30 minutes. Initially, they will be delivered as a remote test, but in a few years off into the future, this will be brought into a regulated product, at which time it can go chairside. These capabilities leverage non-invasive sampling, and this lowers the threshold for valuable testing in this area. And we have an easily interpreted numerical index think of this as a capability that empowers non-expert providers to provide expert-level care. This would happen in primary care settings, but we also have a new focus score, Field Oral Cancerization Universal Score, that looks at individual patients, likely in secondary and tertiary settings, looking for small differences over time and providing an expert capability for those more advanced patients. Thank you so much for your kind attention.